Hello everyone. Today we are talking about vomiting in pregnancy, its causes and management. Causes in early pregnancy are simple vomiting, which is morning sickness, emesis gravidarum, or hyperemesis gravidarum, pernicious vomiting or heavy vomiting. In late pregnancy, it may be due to continuation of the simple vomiting or acute fulminating preeclampsia, or it may be related to medical, surgical, gynecological causes in early pregnancy. So we are talking about first is simple vomiting. Simple vomiting, it is the most common symptom in pregnancy, and the vomitus is small, clear and bile stain and does not restrict the activities of women, and it disappears with or without treatment by 12 to 14 weeks of pregnancy, and it is due to high level of HCG, estrogen or altered immune status. So management is very simple: dry toast, dry feeds, dry biscuits, and avoidance of fatty and spicy foods, supplementation of vitamin B1 100 mg daily, and antiemetic trifluoperazine aspazine 1 mg twice daily, or we can give tablet Diagene or 2 tablespoon Diagene syrup 4 to 6 hourly. It is an antacid. Or tablet Evomin 1 SOS 2 TDS, it is promethazine, or tablet Rentec 150 mg BD. Then comes hyperemesis gravidarum. It is very serious type of vomiting of pregnancy which has got very deleterious effect on the health of the mother, and also interfere in day-to-day activity. Talking about the causes of hyperemesis gravidarum are hormonal: high HCG, estrogen, altered immune status, psychogenic, dietary deficiencies, and decreased gastric motility. Next, what are the metabolic or biochemical changes and circulatory changes that we see in hyperemesis gravidarum are: low carbohydrate intake lead to fatty acid breakdown and ketone formation. So we see acetone in urine and breath, and water and electrolyte metabolism is also affected. Next comes the biological changes. Acidosis is seen due to starvation, and alkalosis due to HCl loss, and fall in sodium potassium chloride due to the loss of salts in vomiting, and rise in blood urea and uric acid due to hepatic dysfunction. So the patient suffers from hypoglycemia, hypoproteinemia, and hypovitaminosis. Next comes the circulatory changes. Hemoconcentration leads to rise in hemoglobin and RBC count and hematocrit values. So there is slight increase in the white cell count with increase in eosinophils, and there is reduction in the ECF. If we talk about clinical presentation, so in early cases the vomiting occur throughout the day and there is no evidence of dehydration or starvation, but in late cases there is evidence of dehydration and starvation. Dehydration like dry coated tongue, sunken eyes, acetone breath in acetone smell in breath, tachycardia, hypotension, rise in temperature. Jaundice is a late feature, and obviously what all investigations we will follow then. Investigations to be followed are urine analysis for acetone, biochemical changes for electrolyte imbalance, thyroid hormone for hyperthyroidism, ophthalmologic examination for retina hemorrhage, and ECG for serum potassium level or hypokalemia changes. Next comes the complication of hyperemesis gravidarum in mother. Neurological changes are seen like Wernicke's encephalopathy and beriberi due to thiamine deficiency, pontine melanosis, peripheral neuritis, and stress ulcers in the stomach. Esophageal tear can be seen due to very heavy vomiting, jaundice or hepatic failure, convulsions, coma, hyperprothrombinemia due to vitamin K deficiency, and renal failure. On fetus usually remain unaffected once the problem is resolved, but fetal risk of low birth weight and preterm birth is significant. Next comes how can we manage the hyperemesis gravidarum. So firstly, hospitalize the patient and maintain fluids. Oral feeding is withheld for 24 hours, and the amount of fluid to be infused in 24 hours is calculated. So total we give 3 liters, half is 5% extras and half is ringer solution, and extra amount of crystalloid can be given, which is equal to the amount of vomitus in 24 hours. Okay, with this regime we can treat dehydration, ketoacidosis, water electrolyte imbalance, and then drugs. So for vomiting, we correct vomiting with antiemetic drugs like promethazine, phenargan, chlorperazine 5 mg, or doxylamine is effective antihistamine for nausea and vomiting of pregnancy. Then we give vitamin B6, pyridoxine, doxylamine 25 mg, and metoclopramide, which is used for gastric motility. So after correcting the metabolic disturbances, we can also give like hydrocortisone 100 mg IV in the drip in cases the patient have hypotension, etc., and nutritional supplementation. So that was it. Nursing care is very important, don't forget that. And thank you so much for listening.